Hello, everyone. My name is Rahul Aggarwal, and I'm a cardiology fellow at Brigham and Women's. Today, we're incredibly excited to have Dr. A.J. Blood from the Brigham and Women's Hospital, Harvard Medical School, who's a cardiologist and also a clinical trialist that will be presenting a late breaker today on the DRIVE study. Dr. Blood, thank you for taking your time. Can you tell us a little bit about your motivation for the study?
Absolutely, yeah. So clinical trials, a lot of times are looking at the mechanisms and effectiveness. Really what we're trying to understand is, there's a big gap in implementation of therapies that we know to be effective. So how do we create strategies and system level initiatives to try to address those gaps and do a better job of getting people on guideline-directed medical therapy?
Wow, amazing. That's an incredibly important question there. And what was the design of the study?
Yeah, so we had a randomized trial. So this was a 200 patient trial looking at patients with type 2 diabetes at elevated cardiovascular and or kidney risk. What we did then was randomize into two arms. The first arm was simultaneous education and medication management. So our remote team actually uses a navigator and pharmacist focused intervention that doesn't allow an MD at each and every step to titrate and start medical therapy known to be effective in patients at high cardiovascular or kidney risk. So what we did was either the strategy of simultaneous medication, education, and management with our remote team, or a 2-month period of dedicated education. That included videos, coaching, nudges both to the patient and their providers to say this person really does qualify for medicines that would improve their cardiovascular or kidney outcomes. In doing that randomization, we looked to understand what happens kind of in this secular trends enhanced standard of care with additional education and notifications versus remote management with our team. Our hope was that in the initial 2-month period, we figured we would have more medications on board in our simultaneous arm because we were prescribing medications as long as patients accepted them. However, after that 2 months, we expected there to be a catch up or even a crossing of the curves where people who had more dedicated education, really focused coaching would actually improve their utilization beyond that in the simultaneous group.
Wow, that's amazing. That's a great design there, and it really helps address an important implementation issue. What did you find in the study?
We were a little surprised. So the first, the primary outcome of the study was prescriptions written by 6 months. So that was significantly different between our simultaneous and our education first arms. With actually the simultaneous arm, more prescriptions at 6 months, and even in a secondary analysis, more people taking therapy. So we actually asked all of our patients in verbal interview as part of the program, are you actually taking the medicines that you've been prescribed? And interestingly, both in the simultaneous and education first arm, we had a significant uptake. There was a gap between those who got a prescription and those who actually were taking the therapy. However, it was a much higher rate of both prescribing and taking in the simultaneous arm, up at about 70% for prescriptions and about 60% for those taking therapy at 6 months.
Wow, very interesting there. Thank you for sharing that. And what would you say is the key takeaways from the trial here?
Yeah, I think, these types of programs I think are essential. And I think my take home message for a lot of the doctors and especially trainees out there is that, we have this model right now where each and every one of you is responsible for a panel of patients, thousands maybe of patients. It's really hard to stay on top of all the new medications, the guidelines, the evidence, and get that therapy on board. Building a system of care is really important. And whether you have the team or resources to be able to provide a navigator and pharmacist-based structure that we were fortunate to be able to do in this trial and for our patients at Mass General Brigham, even if there's not that type of resourcing, being able to have a systematic way of identifying, addressing, and following up these patients to make sure that they're getting on therapy that are going to improve their cardiovascular and kidney outcomes, I think is really the take-home message.
Amazing. That's just incredible and excellent work there. What advice can you offer to future trainees interested in doing such wonderful trials such as the one you did? To watch more videos like this, please check out YouTube, Fellows in Training on the Go, and follow us on X as well at Fellows in Training on the Go.